So thank you very much for inviting PHE and the trial team to give you an update on the PrEP Impact trial. So I'm doing this on behalf of the trial team, which the names of whom will come up later. So to give you a bit of a history of where we are with PrEP and what's happened over the last few years, most of you will know that PROUD reported in February 2015, and they reported an 86% reduction in the risk of HIV acquisition in those taking oral PrEP. For about the last 2 years, Public Health England and NHS England have been working together on evidence reviews and a process of discussing policy for PrEP in England. And this was before the results of the PROUD trial came about, and then after that an evidence review and further discussions about how PrEP could be rolled out in England. In March 2016, NHS England issued a statement saying that they didn't consider PrEP to be within their commissioning remit. This was challenged by the National AIDS Trust in April through a judicial review. The review outcome was that NHS England could commission PrEP, but they weren't obliged to do so. And NHS England appealed, but during that time, the work on how PrEP could be rolled out in England with partners continued. And in November, there was a joint statement by Public Health England and NHS England that there would be a trial of PrEP in England over the next 3 years. So NHS England have committed to funding of £10 million for a trial lasting 3 years, covering 10,000 participants. And the reason for a trial is that there are still outstanding questions that we think need to be addressed before PrEP can be rolled out widely in England. And these are the questions that we think there are. So what proportion of GUM clinic attendees are going to be eligible for PrEP? How do we identify those that are eligible? How many are going to take the offer up? And then two very key questions. How many will choose daily or intermittent dosing? There's evidence for daily dosing for most at-risk groups and intermittent dosing for MSM at-risk groups. What's the duration of PrEP use for those who take up the offer? So that is a primary objective of the trial. Is unclear at the moment, and the impact on HIV and STI incidence, as I'm sure we're all interested in. So all of that have fed into the primary and the secondary objectives of the trial. The inclusion criteria for trial participants are based on being inclusive for all at-risk groups, and not just MSM. But for all persons at high risk of HIV, either because they're reporting high risk of sexual behaviour, or have an HIV positive partner who has a detectable does not have an undetectable viral load, or are they a partner of unknown status and at a risk of HIV acquisition. This is translated into quite specific, because we need to be for the protocol and for trial sites, quite specific criteria for the trial, but still inclusive, hopefully, so not just targeted at particular at-risk groups, but considering serodiscordant partners. And also criteria 3 is very much about clinical judgment for individuals that might be considered to be at high risk but don't necessarily fit 1 or 2. So what the trial means for the participants of the trial is that at the first visit, where PrEP is discussed with trial participants, it's going to be done as part of combination prevention. So we're expecting everyone that goes to GUM clinic is identified to be at high risk of HIV acquisition. We'll have combination prevention discussed with them, and PrEP is a part of that intervention. They have baseline risk tests done for HIV and STI, as they do now. Kidney function tests are particular to PrEP, but they're already in the guidance, because, as you know, PrEP is being accessed by people through other routes already. They are given they're given a 3-month prescription for PrEP, either daily or intermittent dosing, so event-based dosing. And at the moment, event-based dosing is only for MSM, because that's where the evidence is. And the data collection for that interaction is going to be via the routine PHE data collection in GUM-CAD. So patients who are then put on PrEP come back a month later for a follow-up, and then 3 months after that. So in a year, there's 4 appointments for patients on PrEP. And in follow-up appointments, that's the usual HIV, STI tests that are done for all high-risk groups. hepatitis C test, kidney function again for people particularly on PrEP, and a discussion again of combination prevention and whether the individuals are continuing to be at high risk. And if that's the case, then PrEP is re-prescribed, again, either intermittent dosing or daily dosing based on their risk profile. There's also a safety check of if there are any side effects that need to be reported or if there are any adherence issues. And then again, routine data collection via the STI GumCAD system. So the timeline for the trial, you may have seen we've put out, I think it was about a month ago, a stakeholder update that the trial is going to be up and running by summer. So this is the timeline leading us up to it. The peer review of the protocol has been completed. We're underway in terms of ethics submission, so that's started with the sign-off of the protocol. The drug procurement is being led by NHS England, and that's imminent now. Sort of public notice of procurement is imminent. So we're working up to enrolling sites in the summer and then starting the trial by the summer. So just to summarize what we're doing with the trial, 10 million for 10,000 patients over 3 years. It's to answer key outstanding questions. The eligibility criteria for the trial have been discussed with community groups and with clinical groups that some of you may have been a part of over the last two years. So we've had task and finish groups and community advisory boards that have decided on the eligibility criteria that have been added to the protocol. And we're hoping that as many gum clinics as possible in England are going to participate in the trial because we want this to be inclusive and equitable. And we want to mitigate against future geographical inequity. And it's going to, as I was saying, PrEP is part of a combination prevention package. It's not a standalone intervention. So it's going to support regular clinical risk assessment as part of risk reduction. And we're using existing systems to capture the data for the trial. So this is the PrEP Impact trial team on whose behalf I'm presenting. And we'd like to thank the Community Advisory Board, who've particularly helped us with things like the inclusion criteria. If anybody would like to contact PHE in relation to the PrEP trial, those are the two contacts that you can email. Thank you very much.
Thank you very much. Thank you very much, Melanie. As I said, we'll be doing questions after all of the presenters have done their presentations. So next, it's Dr. Alan McCarran of 5016 Street, which has already been mentioned so far. And he will be talking about the rapid initiation of treatment in a central London clinic.
Hello everyone. So I think I should start by saying I'm presenting a lot of slides from my lovely colleagues Neka Nicole and Gary Whitlock, so this, some of which I've bastardized to my own use. And I'm going to be talking about basically starting people on HIV treatment essentially on the day they're diagnosed, which is kind of like tending to get an acronym RAPID now. So when I say RAPID, I mean starting on the day you're diagnosed. I'm going to start by giving a little bit of background about it and then talk about the pilot that we ran at 5016 Street. So 5016 Street is a sexual health and HIV clinic based in Soho. It's a bit unusual in that over 60% of the 12,500 attendances a month are gay men, and it's very rapidly grown. This HIV cohort has gone from about 1,000 to 4,000 in just a few years, and that's partly been based on Rita positive, suggesting recent infection, and it's now about half. So why that focus on trying to pick up the undiagnosed and pick them up really, really early? Well, this is very old data, but I think it stands true now. The vast majority of people, when they test HIV positive, take steps to reduce the risk of passing it to somebody else. So this meta-analysis gives a 68% reduction in condomless sex. Amazing, but there's a 32% of condomless sex still going on. So I think the real game changer has been the realization that being undetectable on treatment essentially makes you non-infectious to other people. The partner study has really changed that. So I'm going to take Valerie's slide she's already shown and change it to try and put what I'm talking about into some context. So I've taken the line of the large fall clinics that Valerie has already talked about and then put various time points on it to show you about rapid treatment. So way off to the left of the slide is the launch of online testing. So that's way off there. Then, if you're looking at from us, the Dean Street Express opens in February 2014, and then we introduce offering HIV treatment at first medical appointment, so about day 14, shortly before HIV peaks. The PROUD trial then appears at the end of 2014. That's when the study stopped. And it's like September 2015, I Want PrEP Now goes live, the BEVA guidelines change, PROUD is published, and various clinics around London launch kind of PrEP support services. Then in early 2016 is when we started offering drug level testing for people buying it online, which certainly at Dean Street had a big effect on people being confident about buying online. And then in July 2016 is when we started offering the pilot of treatment on the day of diagnosis. So not to diss my own talk, but essentially what I'm talking about is not the thing that has caused this major drop. That happened earlier. But to put it in perspective again, Valerie's slide, this is the drop in time from diagnosis to treatment across the UK, and we can see it's been falling. This kind of drive to reduce the period when people are infectious. So what is the background to rapid treatment? Well, this study was presented at AIDS last year, and it's based in Haiti. And they compared what their standard of treatment was, which I think pretty good, which is starting people on treatment at day 21 after being diagnosed, and then they compared it with starting treatment on the same day of being diagnosed. And what they found at 1 year was less people had died, more people were in follow-up, and with an undetectable viral load if they started treatment on the day they were diagnosed. Perhaps more applicable to the UK is the San Francisco RAPID program. Now, obviously, America has more barriers to starting treatment than we might have in the UK. So you have to get insurance cover, and very frequently the person testing you positive is very different to the person offering you follow-up care. So you've got to negotiate your way through these barriers. But in the RAPID program, they managed to, when they compared, again, amazing results, I think, starting people on treatment at day 10 compared with starting treatment on the day of diagnosis. And they found that the time to become undetectable and so non-infectious dropped by about 100 days with no change in retention to care. So if San Francisco is able to do this with its additional barriers, why on earth can't the United Kingdom do it? And I guess that's what was behind Dean Street launching its pilot. So what I want to kind of really pick out, one of the reasons we were doing that was because about half of the people we were testing were seroconverting. And so we were thinking about treating within 48 hours because we wanted to minimize the virus seeding around people's bodies, as well as reducing infectivity. Now, I'd love to say that this was completely driven by all the clinicians and this was our great idea, but to be honest, we were responding to patient demand. So we were sitting there going, oh, is it really safe? And we won't have the resistance test back, and I don't want to feel that I'm pressurizing somebody. And we were getting a subset of people coming and going, I want to start. I don't want to be infectious. I don't want to give it to my boyfriend. I've heard about cure research. I don't want to have a reservoir full of HIV. I want the drugs now. And if I had to paraphrase what the words we were hearing, they were, "I want to take control." And so we were responding to that, to be honest. So I'm going to try and clarify what I'm meaning by different terms. So this is what Dean Street was doing in 2013. I'm going to call it the classic pathway. So you test positive, you have your blood test done, you see the doctor or whoever 2 weeks later to talk about them. You then see them several times over a period of time. And months or years later, you start treatment. So what we changed in 2014 was what I'm going to call the standard pathway, which I guess is what's in the BEVA guidelines now, where you offer someone treatment as soon as possible, as soon as they feel ready for treatment as prevention. And that's easy as a clinician because all the results are back. So at 2 weeks, you can then sit down and have a conversation with someone. Now, the challenge of starting treatment really early, so our target was to offer everyone the chance to start treatment within 48 hours, is a lot of the results aren't back then. So the challenge was, what do you do when you start someone on treatment so quickly? And actually, in some ways, it makes things much easier because with no viral load and no HLA result, everyone's backbone essentially has to contain tenofovir, not abacavir. And without a resistance result back, essentially everyone has to have a protease inhibitor. So the conversation becomes much simpler. It's, do you want to start? Rather than, do you want to start? And if so, let's have a long discussion about what. That happens a week or so later when the other results are in. So if someone wants to start, it's quite simple. The second big challenge was, how do you see someone within 48 hours? And so we had to create capacity in the clinic. We didn't have a walk-in service in the same way that some do. So we reserved appointments back and released them on the morning if they hadn't been used by someone testing positive the day before. So I'm going to present the findings of what happened in the first 5 months of us launching this. So we had 127 people test HIV positive in the 5 months, July to November last year. Overwhelmingly, they were men who have sex with men, and 50% of them were recent infections. So of the 127, 118 of them elected to continue their care at 56 Dean Street, of whom 75% of them started treatment at that first appointment with a doctor. And that first appointment dropped. If you compare it with before the pilot, it dropped from 16 days to 6 days, which was statistically significant. And the time to starting, the median time to starting antiretrovirals dropped from 26 days to 7 days. Now, I want to just break that down for you because if we look here, you can see that about a quarter actually started treatment within 48 hours. About another third started treatment in the first week, and about 60% plus had started treatment before 2 weeks. But you still had a group of people who didn't want to start during that time. And then if we just look at the kind of time to undetectables, this is just the first people in the first 3 months of the pilot, we can see that the time to undetectable, where we've documented that they are essentially non-infectious, is at 62 days. So that compares quite favorably with San Francisco. So I think the key points I wanted to make, I guess there were 3 of them, is one, this is something patients want. Not all patients, but lots of people testing HIV positive welcome this as an option, but it's not for everyone. It's an offer, not a kind of order. Secondly, I would say, I would argue our focus should change. The paradigm has changed for me from, oh, we should aspire to early treatment and early diagnosis and treatment. Our aspiration now should be immediate diagnosis on seroconversion and rapid offer of immediate treatment. We should be aiming much higher than what we're doing it. And lastly, that we can do it. We've got less barriers than America. If we put our minds to it, we can do this rapid offer. So thanks to Gary and Neca again.
Thank you very much, Alan. You really did speed through those slides. That was astonishing. Our final speaker is Carrie James from THT and HIV Prevention England. He's talking about Your Condom Matters, promoting choice to increase engagement with condom promotion. Knowing what a Smith's fan he is, I'm surprised he didn't call it Some Boys Are Bigger Than Others.
That would have been much better. Where were you? Where were you last week? Yes. Thanks, Matthew. And I have to say, it's a great honor to be on such an esteemed panel. I feel like a little bit of a fraud because I wasn't the first choice to give this condom presentation, but because of the election in PERDA, certain people were not able to come today. And as is common in quite a lot of HIV conferences at the moment, the number of abstracts that were presented around condom-related programs were, let's say, very thin on the ground. But we felt it was very important that condoms did have a place on the agenda. So here I am. Condoms are going to remain, even in the time of TASP and PrEP, condoms are still going to remain the best choice for many, many people in terms of HIV prevention and especially for STI prevention. And we know through the work of Andrew Phillips and the modeling that's been discussed earlier that it's estimated that 80,000 infections were avoided in gay men from 2000 to 2010 because of condom use. And I think it's been a challenge throughout the history of HIV prevention about how exactly do we, promote condoms? How do we, get people to use condoms who aren't using it? Some people will because they'll know the facts and they'll want to, protect themselves. But we are asking people to make, a very rational decision at a very irrational moment of their lives, and perhaps, those seconds and those moments that are perhaps most irrational in their lives. So how can we influence those? And I think, it's very difficult. And I think we've tried many ways. We've tried being cute about it. We've tried being scary about it. And we've tried being rational about it. And I think, it's an ongoing thing. How do we create the behavior change that we want? How do we convince or encourage people who might not use condoms all of the time to use them more? And one of the ways that in this country that we try to do this, and this was about 5 years ago, and this was a project that was done by THT in Brighton, actually slightly before I started there, was Brighton's Next Top Condom. And hopefully I would think some of you have heard of this, but it was really looking at the idea of choice and about how the choice of your condom makes a difference. So basically, if you're not familiar with the program, they made up packs with different types of condoms in them. The main pack was all standard size condoms, but different brands. And then there was also a pack that had different sizes that people could try. And then they handed it out in the gay scene, and they asked gay men to feedback on them and say which was the favorite condom, which was their favorite condom. And that condom became the condom that was used in condom provision in Brighton for the next year. And the results there were were very encouraging. 95% of the respondents reported an increase in knowledge of the types of condoms available. 91% said that it increased their confidence in choosing a condom that they would enjoy. And almost two-thirds, or exactly two-thirds, said that if they were supplied with the condom that they liked, they would be more likely to use it in the future. So obviously these are really great results. And when we were looking at scoping out the HIV prevention social marketing campaign, even before It Starts With Me, and we started doing some kind of analysis, these kind of results absolutely make sense. I mean, if you look at all of the reasons that people don't use condoms, there's definitely certain ones that we can influence through things like social marketing and with the budgets that we have available, and there's definitely some things that we can't. So if people say, I don't want to use condoms aren't sexy, you need an awful lot of money and social capital to be able to create a campaign or a program to make condoms sexy. But if people say that they don't like condoms because because they always break on me, because they slip off, because I'm losing sensation from them, that can be alleviated through different choices or different, having an idea of that there is a difference. People spend their whole lives trying to find the best shampoo for their hair or the fabric softener that makes their clothes smell exactly the way they want them. Actually, I do that, so I'm owning that one. But but people tend to think very little about the condoms that they use. They'll use just any condom that they happen to have in their drawer or that they picked up, at a community center and things. And not every condom is necessarily the best for every person. So with all of this in mind, we developed an online tool called the Fits Me tool, and we really wanted to strip it back to make it the easiest that it could possibly be. So it consisted of just 3 questions. One asked about whether people were happy about the sensation that they received when they used condoms. One of them was about size, whether they were too tight or too loose. And then one of them was about whether they had any kind of adverse skin effects from it, any kind of rash or itching, or whether they irritated them. And once you fill out all those questions, you get a specialized report that kind of reflects back what you said, and then gives the recommendations for what you might like to try that might make it better. And at certain times of the year, we've been able to kind of take that one step further and offer them a sample of the condoms that we're saying is actually better for them. So we would have sample packs that we would send out with the suggested one, and that was kind of limited by the amount of our funding, because obviously it's quite expensive. You put something on Facebook saying you're going to get free condoms. Quite a lot of people say yes. So we do have to kind of ration those a little bit. But at certain times within the packs, we're able to put a voucher in there for 40% off their next condom purchase. So we were kind of identifying the behavior to be changed. We were offering them an opportunity to trial it. And then we were providing them with a means to sustain that behavior, hopefully at an affordable cost. And this has been a very popular service. I mean, these are some of the examples that we use to promote it on Facebook. We promote it to both MSM and Black African communities. And over 80,000 people have completed the quiz since we launched it. And we've sent out over 20,000 of these condom packs. And we could have sent out probably 80,000 of these condom packs if we would have had the funding to do that, but unfortunately we didn't. And if we just take a look at a small section of that, of what was sent out. So we've sent out about 5,000 since March when we turned on the packs again, which is about 30% of everyone that fills in the tool actually converts. And for like a web-based intervention, a 30% conversion rate is pretty good. And as you can see, 30% of those orders were from people who ordered condoms that were either larger or smaller or latex-free. So these tend to be condoms that traditionally weren't part of condom distribution schemes. So we do feel like not only are we giving people choice within a normal size, but we're letting them try things that perhaps they wouldn't have tried before if they're only relying on free condom schemes in some areas. But one of the kind of really interesting things that's just kind of emerging that I wanted to bring out today is that we've got to, much better at our website to be able to track people's movements around the website. And this is just a little bit of data that was done by Taku here, my colleague at HT. So we looked at the orders that came from the promotion to Black African communities. And we found that, we did get 950 orders for condoms, but we also had 639 people use the witch test tool, which is a tool that asks a few simple questions to find out what would be the best HIV test for you, whether that's a clinical test, a self-test, or a home sampling test, and other HIV-related behaviors. So, when we got people thinking about what condom they should have, people were always also thinking about HIV testing and maybe there's a choice in HIV test, what HIV test we could have. So we're going to really interrogate these numbers a lot more so we can have a much better report. But I think it kind of shows, an added benefit to engaging people with condoms online and choice and the power that can have. So just really quickly in summary, that especially for gay men, that choice, pleasure, and performance have been shown to be effective ways to engage people with condom use, that the correct condom can affect a man's intention to use them, that online platform is a way to engage individuals at scale in large numbers and identify behaviors and then provide those people with solutions. And I think, kind of what's emerging and kind of exciting for us is that engaging people with condom promotion can also lead to other behaviors, other desirable behaviors, like using HIV testing tools and accessing HIV testing information. Thanks very much.
Thank you very much, Carrie, and all of our speakers. And now it's time to turn it over to you. If anyone has any questions. Teku, you're on mic duties, thank you. You've just walked away from the first person to put their hand up. So if you could all introduce yourselves before you ask a question, that'd be great, thank you.
My name is Brighton Chireka. I'm a GP in Folkestone, Kent. I just want to ask if, because you get some patients who come and ask you for PrEP online, and then I get confused, which should I recommend, which are the websites to recommend if they want to buy PrEP online?
I'd go to I Want PrEP Now or Prepster, really. That would be my two first choices. If you use Google I Want PrEP Now or Google Prepster, they both come up as the first search result, and they're great.
Yeah, I think they both have a provider which they're recommending at the moment, and partly that's because that particular provider not only offers very cheap and reliable service, but that provider is also actually providing them with information about the people who are accessing the service, which of course is really valuable for us in terms of monitoring how many people are using PrEP in the wild, as it's still being called. So if you go to the websites, it will say what that provider is, but there are a range of different providers which they are recommended from there.
Oh, sorry.
Not yet.
Catherine?
Sorry about that. Catherine Dodds from University of Glasgow, and I've got a question for each of you, if that's allowed, Chair. Okay. First of all, Nalini, you suggested that the ethics submission has just been sent off because the protocol is ready for the PrEP trial. So if you're looking to have as many GU clinics involved, I'm guessing that's going to involve local ethics approval for every clinic. So I'm just trying to marry that up with the expectation that you would then have initiation of enrollment in what's being called the summer, because you know, my experience with trying to achieve that many different ethics committees, I really honestly can't see that being achieved until the autumn. So I'm just wondering sort of what the expectations are there. Alan, you kind of started to answer my question that I was going to ask you right at the end about the fact that starting treatment immediately on the day or within 48 hours is definitely not going to be for everyone. The recognition that the people attending your Dean Street clinic are unusual folks, and they really need Dean Street, and it's fantastic that it's there for them. I guess, you know, what we're talking about is people with a high level of literacy around health and certainly around HIV and HIV treatment. And so to put together all those things to make a demand is really great that you guys are hearing that. I guess my question in terms of the generalizability of what we're talking about for 48-hour access and recognizing power dynamics when doctors suggest things to patients and ensuring informed consent, I think my overriding question in a lot of the introduction of new technologies now is, what's the implication for the introduction of this for the most vulnerable? And how do we all collectively try and consider that? Because certainly there's a lot of qualitative data out there that a lot of us will be familiar with that says, you know, people who are receiving an HIV diagnosis, unless they're really informed people, are swamped with emotion, and they can't make decisions that day or that week or the next week. So how are we going to acknowledge their needs? And I know you acknowledged that at the end. I just think we all need a bigger conversation about that. And Carrie, I'm so thrilled to hear about condoms. You know, we're talking about the fact that you can't get the funding to send out condoms to people who are saying they're interested. So I just wonder if you could kind of articulate what the costs are for, you know, I don't know, per pack or per thousand or whatever. And actually, the fact that in 2017, we can't raise funding to send out condoms is what we need to be talking about.
Mm-hmm. Thank you. As there were 3 questions, I think we should answer those before taking any more questions. So,
Yeah,
Nalini?
okay, so completely recognize that doing a big bang approach on 200 clinics is going to be quite difficult. So we're working on an implementation plan, and it's very likely to be staggered exactly on the basis of how quickly people can get it through the R&D and various other considerations. But we're working to that, and it's still by the summer that we're intending to do that. I don't know if John wants to pitch in.
Alan?
Thank you for the question. Yeah, no, I do hear you on that one. But I have to say, I do feel quite strongly that you shouldn't just offer something to well-educated gay men, that everyone should have that choice. And I think even though I kind of might make a big thing about RETA positivity rates being 50% at Dean Street, in the rest of the UK, they're still about 25%. And I think you can never go back to that day when someone has got that option to reduce their viral reservoir. And I think someone doesn't have to make a final decision that day. So you can often speak with someone and say, look, this isn't an irreversible decision. Here, start now. We'll see you in a few weeks' time. See how you feel then. And if you want to stop, you can stop. So I think it is in the sell, if you like, or how you support someone. But yeah, totally. People are, if anything, need more support who are starting so quickly, because there's a whole load of things that used to be spread across a year that happen in the space of 2 weeks. And I think that is a challenge, but I still think we should offer it to everybody.
And then finally, Carrie, if you can address the perennial issue of actual investment in HIV prevention.
Yes. Well, I mean, I think obviously we'll be talking about this afternoon as well. I mean, condom provision is really meant to be something that's provided on a local level by local authorities. But we kind of lobbied quite heavily to be able to provide this through the national program. But I totally agree. It would be amazing to be able to offer this all year long. So we're kind of there's two things that we're looking to do this year. One, we're looking to increase or enhance our HIV test finder to include local condom provision. So at the end of the quiz, if we aren't able to offer them our sample, that if there's we can signpost them to the condom provision in their area. And a lot of those are postal services. So that's kind of the first thing we can do. And the second thing is we're constantly working with brands in order to try to get them to donate condoms for us, and Sante has been very generous with giving us very deep discounts on things. I think in terms of the price of the packs, I think it's somewhere, I mean, Taku knows.
Yeah, I think the main thing where the price problem comes is to do with the sensations options, because I think the other sort of the larger, smaller condoms are actually fine, like in terms of pricing. So to put into context, to get a 144 pack of a smaller condom, it costs about £6.99 or so. But to buy a 144 pack of a much more sensitive condoms costs £33 for the same packet of condoms. And it is actually the lube, because I think probably one of the key things to mention about this is that the packets also contain lube, and it is the lube as well, which is much more expensive. So the Sensations pack is the most popular pack in terms of what people order, about nearly 70%. But the challenge then is that is the key cost point. The other bits are actually not too difficult.
Thank you. I think it's quite unusual that we actually have the person who's walking around with the mic answering the questions. So what we're going to do now is if I can take 2 or 3 questions. So Winnie and, I can't see, Winnie and the person next to you.
Thank you. My name is Winnie and I'm a freelance consultant. Thank you for the presentations, outstanding. And I'm just going to raise the points around the issues that you've all touched on in terms of the trial, in terms of treatment being offered when people are diagnosed, in terms of condom, and relating this to women, and mostly to African women who are, let's say, heterosexual. And what difference would that make in terms of all the different issues that you've talked on, you've touched on, because we had in the plenary around not just women, but the African population in terms of being diagnosed in the clinic, that, people don't go to the clinic as much as other populations. But also tagging on to what Catherine said, the level of information that, Black communities have in terms of information around HIV, around all of that, and how they are reached. But also, for me, I believe that PrEP really offers the first sort of prevention tool that really women can hold in their hands. This is, for me, the first. As many prevention tools there are there. Condoms, I'm not even sure, if women, are able to negotiate the condom issue very well. So I'm sorry, my question is very loaded or whatever, but I want you to think about that and let me know what impact there is in terms of people having knowledge, in terms of information campaigns, in terms of workshops, and the level of information that they have before they turn up to clinics or to the trial or to purchase condoms. Think women, more than anything else.
Hello, Alistair Hudson, HPE. Thanks for your presentations. Further to Catherine's point, I think PrEP's done what PrEP now have been brilliant solutions for many, many people, but not everybody has the resources to engage with that, which is a challenge for many. But the thing that I'm keen to explore is understanding the local approvals process, the timeline that's been published, because it is now out there. What's in place to manage people's expectations, bearing in mind an understanding of local challenges in terms of getting this through? The timeline, I would suggest, is will be challenging to manage effectively.
Okay, so Nalini, did you want to respond to Alistair's question? And then perhaps the whole panel can respond to Winnie's?
Yeah, I completely recognise the timescale is challenging. In terms of, so that's why we're thinking about an implementation plan and a staggered approach to doing this across various clinics. So it's highly unlikely that we're going to be able to do this on the same day in all 200 clinics. So the likelihood is it's going to be based on how quickly clinics can get up and running. And one part of that is the R&D. So that's possibly what we're likely to need to do. What did you mean by local challenges other than that? Yeah, no, exactly. And that's the bit that's going to be variable across clinics. And also there are criteria for clinics, like if they can do enhanced reporting on GumCAD that they'll need to implement. So things like that will mean that they're probably not going to be all on the same day. So we'll need a sort of rational implementation approach for all of them. But it's still, we are planning to start in the summer.
And if people could respond to Winnie's question and observation.
I really hear you, Winnie. I completely agree. And I think one of the, I'm maybe not the best person to be answering about how best to reach Black African communities, but I think for me, it's quite easy to reach a high-risk gay man. Most gay men are aware of their risk and won't be in any way offended when you point that out to them. Whereas I think if we're looking specifically at heterosexual Black women, African women, it's hard, isn't it? Because there's an awful lot of heterosexual Black African women who really aren't at any risk of HIV at all. And there are a whole load of them who might be at risk but have no perception that they're at risk. And so how do you deliver that kind of culturally, sensitively, so that you reach the right people without alienating a load of people who it's not needed for? And I think it's a real challenge, and I personally don't have an answer to that, but I think that's what we need to find. don't know if that helps me. I don't think that's not really at all helpful.
And just in terms of promoting condoms to women, and specifically African women, I mean, there's just so much that we can do in terms of the national program. But for the services and the advertising you see there, if we did have ads specifically targeting women, for them to be able to use the quiz and to get condom samples that they could have to suggest to their partners or whatnot. And we do provide the condom resources that we have, that we provide to local organizations around condoms, do feature women as well as men. And we do try to make sure that they're gender neutral so that people can have that conversation, with a variety of people.
Okay, thank you. There's a lady here in the middle who has, I think actually you had your hand up right from the start, so.
That's fine. Philippa Matthews, GP. I'm thinking very much about the roles that GPs can play both in referral for PrEP and in referral for rapid treatment. With respect to referral for PrEP, I think general practice is very accessible to people from high prevalence populations and women, African women. But we know there are other barriers. It's not about who walks through our doors, but it's about what then happens. Teaching rapid risk assessment and really strategic, quick verbal strategies to GPs does impact on their practice, and specifically with HIV testing. But I think one of the things about the use of rapid risk assessment with all the provisos and problems with that is that a negative test becomes much more meaningful than, say, population screening or screening of new registrants. We actually are identifying people who really would benefit from a test, and therefore the negatives could refer for PrEP. And I think that there is real potential in that. GPs are very interested in rapid risk assessment, and it brings for them lots of other opportunities like risk of unwanted pregnancy, risk for chlamydia, and all sorts of other things. So it feels like, seems to feel like good use of their time. And we've got published evidence on all of that. So the other angle of this is how to, if I do make a diagnosis, how to really accelerate access to care. And a long time ago, I was arguing that HIV referrals should be integrated to the 2-week wait system, referral system that we have already within the NHS, which would normalise it. GPs aren't looking anywhere else but the normal referral system, instead of exceptionalising HIV. And that really never worked. There was, I think, frankly, basically myths about confidentiality and things, and there was no desire to normalise it. And there's always been this kind of invent your own referral process for HIV referrals. And that's further inhibited by this not being at scale. So a middle-sized practice in a high prevalence area might diagnose 1 new HIV positive a year. So that's, 4 doctors, 1 new diagnosis. So it's not happening at scale. But it would be really good to look at that whole chain. We've got, I believe that rapid testing is quite difficult to assimilate into general practice, that venous sampling is definitely at least one modality that's very useful, but of course that's a slower result. So that presents the first challenge, is the time between taking the test and, or indeed ordering the test, taking the test and waiting for the result. That then becomes a new, fresh delay that we're now looking at with new eyes. I wonder to myself, with your population, very, very, as we've understood, educated and informed, but also super high risk. I see the men who have sex with men who aren't at risk, or at much lower risk. And I think that, as somebody's already alluded, a lot of the Black African population would be at lower risk. So maybe the window suddenly becomes a bit less urgent in comparison with the group that you're dealing with. But the average age is a bit older, and there are all sorts of other things going on informing that. I certainly remember some of the figures from the Proud and IPA studies that showed that people were just at super high risk and do recognise that and do access different services. And so we maybe don't need to charge into shortening the window massively if actually there isn't the same level of sustained risk in those early days as there is in your group. And then finally, a specific question. You're seeing seroconverters. We are too, but they're really hard to spot. I think I've diagnosed 5 in my career of sore throat illnesses coming every day. diagnosed 5 in 20 or more years, so it's difficult for us to do. But what diagnostic, are you using a rapid test that looks for antigen, and I'm sure that the positive predictive value in my population is still not good enough. I just wondered how you diagnose your seroconverters quickly.
Yeah, so a not insignificant number of them are presenting for PEP, actually, and we do a finger prick test on them and they're negative, and send off a 4th generation lab test, and a day later discover that they actually are seroconverting because the 2 tests are different. So if someone reports recent risk, we'd always do a 4th generation test, which usually involves sending it to the lab because the point of care tests aren't as sensitive as the lab ones.
Okay, so that's 24 hours, which is a wee bit quicker than ours would be.
We've just got a couple more minutes, so there's a question here. Are there any other questions?
Good, because I've got 2.
Oh.
Alan.
Well.
So, hi everyone, I'm Laura Waters. I'm an HPE doctor around the corner at Mortimer Market Centre. Alan, I applaud what Dean Street does, of course, and I do think for some people it absolutely is the right choice. I'm just a bit concerned because Dean Street has an awful lot of influence on what the rest of people do and what we think is appropriate. And I think we need to acknowledge the lack of evidence really to support this strategy. I think first, when it comes to reservoirs, my understanding is that even Dean Street, you're not going to be testing people quickly enough. There'll be a small proportion, but most people, that reservoir gets seeded so quickly that you've got to be treating at stages that really don't get picked up by standard tests at all. Secondly, I think we have to acknowledge that by starting people on protease inhibitors, you're starting people on drugs which have actually been inferior to some of the other options, and whether you do have that discussion that it may not be the best option. And I think, I'm sure you've presented the data elsewhere, what proportion of people did switch when you had the relevant HLA, etc. Of course, cost, I don't think cost should be the driving thing, but we all know that it is. And certainly Truvada and a PI, we all know, is one of the most expensive regimens we can use. And have you had any barriers or issues with the commissioners? Because I think we certainly, at our clinic, we'd be expected to have to go through an MDT, and is that a barrier for you? And then just a question, Nalini, about PrEP. I was involved in some of the precursor discussions and the draft proposal, which of course stopped, and now it's going to be the trial. But one of the real barriers that we had was how to identify within heterosexuals a group that was going to be high risk enough to meet, say, that WHO threshold for HIV risk over the forthcoming year, that was going to make the funders confident to offer PrEP to that group. And it was just an ongoing discussion. No matter how you cut the PHE data, finding that very high-risk heterosexual group was proving pretty impossible. Is that something that you've addressed, or has there been any updates since then about how do you pinpoint the very high-risk heterosexuals?
So, Alan, do you want to
So of course, I'd love to say that nobody looks at our funding, but they do. Yes, we've certainly, that's been very closely focused. So the vast majority of people do switch, and switch very rapidly now. So they'll come in at about 2 weeks, and then the result of the resistance test will be back. I have to say, most people at that time point do not switch onto efavirenz. I think most people will switch onto raltegravir. I think it's quite hard when you're 2 weeks in very early on to go, and now I'm going to give you something that will make you feel completely stoned for the next couple of weeks. So that is an issue. And then you had a second point, wasn't it? I forgot what it was now. Oh yeah, about the evidence. Well, I think I would point to the San Francisco data. So they were comparing people starting on day 1 and day 10, and they were finding people were undetectable and showing them undetectable 100 days faster on median. And in a group where there's a lot of risk behaviour, a lot of people do change their sexual behaviour, but we have a lot of people who, for whatever reason, don't, for their chems use or whatever. I think getting people undetectable that much faster is a valid thing to attempt to do.
Sorry. I guess the other thing is, obviously, with people living normal life expectancy, starting treatment earlier, that's a whole lifetime on treatment, for now, certainly based on what we know. It's that foundation for lifelong adherence. And do you have any concerns that perhaps starting people at such a critical time, a stressful time, are we risking poor adherence 1 year, 2 years down the line? Is that something you're going to keep an eye on? I'm sure you
Yeah,
are.
I mean, it's certainly nothing that we're actually seeing. I think what has been interesting, I didn't present it because Gary has only got a small amount of data. We're going back and asking everybody at 6 months and going, was this the right decision for you? Did you think that this was the right thing for you to have done? Did you feel pressurized? Do you regret your decision? And apart from the fact that most of the questionnaires just say, Gary Whitlock is the loveliest man I've ever met, they all are coming back. Yeah, we haven't had anyone saying, I regret what I've done. They're all saying, no, this was the right thing for me. I didn't feel pressurized. So that which is really nice to hear, actually.
Yeah, so that's an easy one for me to answer because I'll refer to our clinical lead, one of our clinical leads, John Saunders. I'm afraid that's not it.
Hi everyone, I'm Hamish from the GumCAT team at Public Health England. So whereas you're right, the incidence of HIV, in particular in gay and bisexual men, that subset that attends GOM clinics and have a history of a bacterial STI is something like 3 per 100 person years. So the incidence of HIV in heterosexuals is markedly lower, and we haven't interrogated this as thoroughly as we can because the numbers are smaller, but it's almost that we've started exploring a proxy analogous measure for high risk of HIV, which somewhat counterintuitively is associated with less HIV testing. So if you look at people, heterosexuals who don't test for HIV regularly, their incidence going forward for HIV tends to be higher than those that do test regularly. So I think that speaks to health-seeking behavior. We haven't had time to explore this fully, but just as preliminary findings, I wanted to share that.
Okay, thank you very much. That is all we have time for, because I've heard the trolleys being wheeled along the corridor for the food, which will be being served in the West Corridor and in the Ada Salter Suite. I'd also like to remind everyone that there's a lunchtime session on how to apply for the Public Health England Innovation Fund, and that's in the George Fox room on the 2nd floor. As I said at the beginning, I think this is a very exciting time to be involved in HIV prevention, but certainly the discussion and the questions that have followed have revealed that the struggle is far from over and the path ahead is still treacherous and scary at times. I want to thank very much all of our speakers, Nalini, Alan and Carrie, and thank you all.